hypertension. We can diagnose hypertension only by measuring the blood pressure multiple times. We cannot measure the blood pressure and find it high or abnormal and say this patient is having hypertension. Hypertension is a diagnosis of following up the patient for multiple times, at least 2 to 3 times. So every 2 years, for person with systolic and diastolic pressure below 120 and 80 millimeter mercury is the time we measure blood pressure. So if you have a normal blood pressure, you measure it every 2 years if you are normal health susceptible. And yearly for a person with a blood pressure of 130 to 139 or a diastolic of 80 to 89. Okay, this is the screening for the blood pressure. So the technique, we can measure the blood pressure in the office. We can connect you with a device and let you go, and the device will monitor the blood pressure while you are while you are ambulating. This is called ambulatory blood pressure monitoring or self measurement by
أنا ما
electronic device.
شايفة الشيرد كونتنت. أوكي
أنا
Yeah,
برضو ما شايفة. أوكي.
كده
خلاص
كويس.
ظهرت. أوكي
So in office, two readings in the doctor office, 5 minutes apart. The patient must be sitting in chair. Confirm elevated reading in the contralateral arm. Okay. Ambulatory monitoring indicated for evaluation of white coat hypertension. White coat hypertension is an increase in the blood pressure due to stress from visiting the doctor. So it's considered because there were absence of 10 to 20% of blood pressure decrease during sleep, and this may indicate an increase of cardiovascular risk. So actually, ambulatory blood pressure monitoring is used mainly for sleep monitoring of blood pressure and monitoring of something called night dip. Night dip. So the night dip
بحثك جميل.
is a شكرا. So the night blood pressure dip is an important factor for assessing future blood pressure abnormalities. Self measurement can occur at home, and also it used to evaluate the potential white coat hypertension. So in the absence of end organ damage, the diagnosis of mild hypertension should not be made until the blood pressure has been measured on at least 3 to 6 visits. So once there is no symptoms, there is no end organ failure or any damage, you have to delay the diagnosis if there is no symptom as long as possible. Not good to diagnose a patient with a chronic disease that mandate long time management from one measurement of a blood pressure. This is very bad. Obtain multiple blood pressure measurements. You should measure the both arms, and the systolic must be equivalent in both arms. Disparity of more than 15 millimeter mercury indicate subclavian stenosis. So if you measure both arms and you found more than 15 millimeter mercury differences in systolic blood pressure, you suspect peripheral arterial disease like subclavian artery stenosis. Okay? How how we suspect subclavian artery stenosis apart from this measurement. Uh, what are the symptoms, or what is the main symptom that present in patient with subclavian artery stenosis? So the subclavian steal syndrome is because of the nature of the vertebral artery, long length, and small radius. The subclavian steal the blood from it. Postural hypotension is defined as drop in the blood pressure more than 20 millimeter mercury in the systolic during raising from supine to upright position, and always must be monitored in patient elder than 56 years old, and all patients who are having dizziness or weakness upon standing, and those with diabetes, because diabetes causes autonomic neuropathy, and autonomic neuropathy is one of the causes of postural hypotension. Other causes of postural hypotension are obstructive jaundice, Addison disease, and so. White coat hypertension and ambulatory monitoring is white coat hypertension occur in 20 to 25% with stage 1 office hypertension. 25% of patients with stage 1 office hypertension, they are they may have white coat hypertension. They may be nervous because they are meeting the doctor. So you may follow them up with ambulatory blood pressure monitoring, but everything that we do have its limitations, because ambulatory blood pressure monitoring can monitor the blood pressure during stressful events while the patient is at home and we don't know about it. So sometimes, just because the patient, his son, maybe he's falling from a chair or something, patient may be stressed and the blood pressure recording may go high. So we don't know. This is why chronic or long-term monitoring of blood pressure may be associated with higher reading, false readings, because of the stressful life events. So it records the blood pressure intervals 15 to 20 minutes during the day and every 30 to 60 minutes during sleep. This is the most accurate during sleep. So we cannot use ambulatory blood pressure monitoring to assess stress in a good way, but we can use it to assess blood pressure when it monitors the blood pressure during sleep. Can be used to confirm or exclude the presence of white coat hypertension in patients with resistant office hypertension but normal blood pressure reading out of doors. So our indications for the arterial blood pressure monitoring, in addition to patients with suspected white coat hypertension, should be considered for suspected episodic hypertension cause like pheochromocytoma. Also can be used for resistant hypertension, can be used for hypotensive symptoms while taking medications, and autonomic dysfunction. These are the indications or for ambulatory blood pressure monitoring. So continuing with our patient evaluation, now you know how to diagnose blood pressure. You need to monitor the patient and to record the blood pressure using the sphygmomanometer more than 2 times, especially if the patient have no symptoms or organ failure. If the patient have indications for ambulatory blood pressure monitoring, you do it. Then if you diagnose hypertension, then you evaluate the patient. And how you evaluate the patient, we will see. So 3 objectives: assess the lifestyle, reveal identifiable causes, reveal and identifiable causes, and assess the presence of target organ damage. So you will check for risk factors, primary and secondary. You will check for the complications. Okay, very simple. Important aspects of the history and exam patient with hypertension. You will focus in the history to identify primary risk factors, secondary risk factors, the symptoms associated with the primary risk factors, the symptoms associated with the secondary risk factors, and the complications. You will focus with the investigations with the primary risk factors, secondary risk factors, and the complications, and you will be guided by physical examination. So, duration of hypertension, prior treatment of hypertension, intake of agents that may cause hypertension. So this is the history. You ask about the duration. If the patient is having hypertension or he is monitoring his blood pressure, when were the last time you had a normal blood pressure without taking a medication if you are hypertensive? If you are not hypertensive, when was the last time you measured the blood pressure and it was normal? When did it start? So last known normal blood pressure and course of the abnormal blood pressure, prior treatment of hypertension, drugs, types, doses, side effects, and medications that may be the reason for this patient abnormality, like steroids, like cocaine, like excessive salt intake. Family history and symptoms for secondary causes. Family history for hypertension, like does anyone of your family have high blood pressure and take medications or no? Is there is any premature cardiovascular disease in your family or ischemic heart disease? Is there is any familial diseases like pheochromocytoma, renal vascular diseases, diabetes, and gout? Symptoms of secondary causes like muscle weakness, spells of tachycardia, sweating, tremor, thinning of the skin, flank pain, and so. So the flank pain is a symptom for renal vascular diseases. Tachycardia, sweating, tremor, and thinning of the skin indicate Cushing. Tachycardia, sweating, tremor, and muscle weakness indicate pheochromocytoma. Pheochromocytoma. Okay. So symptoms for target organ damage like headaches. Headaches may indicate encephalopathy, posterior reversible leukoencephalopathy, and transient weakness or blindness, which is clinical blindness and indicate posterior reversible leukoencephalopathy. Loss of vision and chest pain. Loss of vision indicate retinal damage. Chest pain indicate myocardial infarct or left ventricular hypertrophy and failure. Presence of other risk factors such as smoking. Do you smoke? How many packs per year? For how long? Are you diabetic? Do you take insulin, metformin, any medications, or you don't? When you were diagnosed, do you have any lipid abnormalities? Physical examination to detect xanthelasma, physical inactivity. Do you exercise? How many times? Do you run? Vigorous or non-vigorous exercise, aerobic or non-aerobic exercise? How many miles do you run per week? And so you have to ask about the dietary history. Do you eat large amount of sodium? Do you take alcohol? How many do you eat food that contain high saturated fat? Do you have any psychological factors? You have work stress? family structure. Are you uh, are you a mom with an unsupported husband that leave you all the time with your children, causing you anxiety and stress? Educational level, sexual history, and sexual function. Is it normal? Because some diseases like Cushing syndrome, some diseases like primary adrenal hyperplasia may affect sexual function. Features of sleep apnea, early morning headaches, daytime somnolence, loud snoring, and erratic sleep because obstructive sleep apnea causes hypoxia, and hypoxia causes vasoconstriction, lead to pulmonary hypertension and secondary systemic hypertension. They have severe hypertension sometimes. Important aspects also may include accurate measurement of the blood pressure. You have to look for the general appearance of the patient, distribution of the body fat, skin lesions, and muscle shrinks because of the Cushing syndrome. You have to do fundoscopy. You have to assess the patient for retinal hemorrhage, edema, cotton wool spots, which indicates hypertensive complications. And you have to check the neck for carotid bruits and the thyroid, as hyperthyroidism may causes hypertension. You have to check the heart for the size, rhythm, sounds, and you have to check the lungs for bronchi. You have to check the abdomen for renal masses. All the physical signs of secondary causes and the complications of the hypertension. You have to be careful when palpating the extremities and checking for peripheral pulses to assess the patient for atherosclerosis, lymphoschemia. You have to do good neurological assessment and visual disturbances and focal weaknesses to assess the possibility of encephalopathy or stroke. And then you will move forward to do some tests, and you have to be specific and considerate for your physical examination and clinical presentation. If the patient is having abnormal body shape, moon face, obesity, you have to test the patient for Cushing syndrome. If the patient is young, is having sweating, increased spells, he have or she have panic attacks, multiple panic attacks, and very high readings, periods of hyperglycemia, you check the patient for leukocytoma. If the patient is having large thyroid, she is lean, she's having weight loss, and the symptoms of hyperthyroidism, you check the patient for thyroid function. And if the patient is diabetic and is having uh, primary hypertension diagnosed for a while, then you check the patient for complications. And so, like that. In the next session, we will talk about investigations in details.